Before we learn how to perform a spinal anaesthetic, it's important to review some essential neuroanatomy. Here is a diagram of the lumbar spine in sagittal section. As you can see, the spinal cord ends at about the level L1, L2. That's the yellow structure in this diagram. Hence, we like to insert our needle well below this, so there's no risk of hitting the spinal cord. In this picture, we've inserted the needle between L3 and L4 spinous process, but you can go even lower than that between L4 and L5. As you're inserting your needle, it's important to imagine the tissue planes that you will go through. As you become more proficient at this technique, you will learn how each tissue plane feels. The first tissue plane that you go through is the skin, followed by the subcutaneous fat, which is soft and easy to inject into. The next layer is the supraspinous ligament, which becomes hard. After this, it's the interspinous ligament, and then the ligamentum flavum, which is a very hard structure, but not as hard as bone. The final structure you go through before entering the subarachnoid space is the dura and arachnoid, after which point you will hit a fluid-filled cavity. In cross-section, this is what you will imagine it looks like. So the subarachnoid cavity, in blue in this diagram, is full of cerebrospinal fluid. Hence, once you enter this, you'll get a distinct loss of resistance. And once you remove your introducer, clear fluid or CSF will exit from your needle and you'll know you're in the correct space. Once you are certain you're in the right space, you can then inject your local anaesthetic, which in this case is heavy bupivacaine 0.5%. The heavy bupivacaine will move throughout the CSF, and that will be determined by gravity because it's heavy. As it moves throughout the CSF, it diffuses into the spinal cord and blocks transmission of nerve impulses. To understand what happens next, we need to think more closely about the spinal cord anatomy and the tracts which carry specific nerve fibres. In this diagram, the sympathetic chain is green, and as you can see, it's superficial and thin. So it will be blocked almost immediately. And because it usually provides vasoconstriction to the blood vessels, the patient's blood pressure will almost certainly drop. As you can see, the gracile and the cuneate fasciculus carry proprioception and vibration. So the patient is going to lose the proprioception in their legs. The red tracts, which are quite thin and also superficial, are the spinothalamic tracts, and they carry pain and temperature. Hence, they will be blocked quite early as well. And we can test if they were blocked either through causing pain to the patient, which is what the surgeons will do later, or by using ice. And that's how we usually check our block. We'll put ice on the patient's skin and ask them, does it feel cold? If they say no, then we know that the temperature is blocked and therefore the pain will be blocked. Finally, the yellow tract or the corticospinal tract carries motor fibres. So the final test of your block is to ask the patient to lift their legs in the air. If they can't lift their legs, then they've lost all motor function in the legs. You can be confident that your block is working. Hello, Mr. Dugan. Nice to meet you. My name's Dr. Woolard. Now, I'm your anaesthetist today, and I've actually been told that you've had a bad reaction to a general anaesthetic before. Is that right?
Yes.
So what I thought we'd do today, you're getting your knee operated on today, and I thought what we'd do is avoid a general anaesthetic completely and give you a spinal anaesthetic. Now, what I mean by a spinal anaesthetic is that we'll put a needle, a very small needle that goes in your back, and it allows me to inject local anaesthetic into the fluid that surrounds your spinal cord. And it means you can be awake for the operation, but you'll just be numb from about the nipple level down, all the way down to the bottom of your legs. Allows the surgeon to operate on your knee and you'll feel no pain. There's many benefits to a spinal, but for you it's the main benefit is avoiding a general anaesthetic and avoiding a reaction. But also it's really good for pain relief. Now some of the risks of a general anaesthetic, the risks of a spinal anaesthetic are that it may not work, and if that's the case then I'll still have to put you to sleep and we'll do it in a safe way for you. Other risks that you can have a bad headache after a spinal, that's very rare. And other even extremely rare risks are that you can get an infection or a bleed into the spinal cord. That's very rare. If it does happen though, you can lose the power in your legs. Generally, spinal anaesthetic is very safe. Alternatively, we could put you to sleep, but I think a spinal anaesthetic is a better option for you. Do you agree?
Yeah.
Do you have any questions for me before we proceed?
No, I haven't.
Good. I'm going to need you to put that under your arms and drop your arms over the top of it. That's good. Now, so sit up straight, drop your chin to your chest, slouch your shoulders. That's good. Now, I want you to try and curl up in a ball. Now, when you do that, that's great. I'm going to push this up. And I'm just going to zoom out a little bit and show that the lumbar vertebrae are poking out and are very easy to see in this position. And what I'm going to do is I'm just going to show the surface markings that we're going to be feeling for when we're doing the spinal anaesthetic. Firstly, we need to check where the midline is, so I'm going to run my finger down there. And I can feel that that's pretty much the midline. Next, I need to feel the iliac crest, which I can feel nicely there. And I'm going to draw a line, which I'm going to be able to see when I'm doing my spinal. Iliac crests are around about there, and they're usually at about a L3 level. So if I go, this is the midline here, beneath where the iliac crests are, and I feel that there's spinous processes poking out, and right there's a gap between the spinous processes. X marks the spot where I'm going to do my spinal anaesthetic. And then we go along to the space beneath that, and you can see the spinal cord should have ended by that point. And this is the gap where we need to put our needle. So you'll see when I insert it, I feel down the spine and try and insert my needle between the two spinous processes where there's a gap. Okay, so now we're going to perform a spinal. As you can see, I've prepped the skin and I've put a sterile drape on. Everything on this tray is sterile. So first I'm going to draw up my local anaesthetic to numb the skin, which is lignocaine 1% in this case. We'll draw that up in our syringe. All of this is sterile. And I'm going to attach a needle to it. And this is to numb the skin, but it can also be used as a seeker needle so that you can try and feel where the right space is. So I'm going to feel the iliac crests here. And then I'm going to put my finger down the midline, which is feeling the vertebra. And I can definitely feel there's a space between the vertebra here. Hard spot, spinous process below that spot where I'm going to inject local. So I'm going to inject local where the spot between the spinous processes was. And as I inject, I'm feeling where I'm going, so that's hard. So I need to go beneath that, injecting local subcutaneous tissue. Now it feels like I'm in the ligaments. And I'm injecting and numbing all of that skin. Feels like I'm in the right spot, so I'll leave the needle in to remind myself where to go. Then I'm going to take that needle out and insert my introducer where it was. It's hard to see in this. So I'll go introducer, same spot. Feels like I'm in something hard which resembles a spinous ligament. Introducer, in this case I'm going to put it all the way in the hub, and notice I'm still in the midline. Now we're going to put in our 25 gauge Whittaker needle and line it all up. As you can see, the tip is a pencil point and it has a bevel which I'm going to face upwards, which is in line with this little groove here. Now this is going to go into my introducer, which just helps me guide where the needle goes because it's a very thin little needle. I'm going to push, push, push until I feel like I'm going through the ligaments, hitting something hard, so we're going to angle up. Now I feel like I've gone through the ligaments, loss of resistance. So I'm going to pull the introducer out, and that's when you'll see fluid dripping back. Once you've injected all of your local anaesthetic, which I have now, you're going to pull out everything all together. Okay, now that we've performed the block, we need to check that it's working. So I'm going to ask first, Mr. Dugan, can you please lift up your left leg in the air?
I can't lift it.
Can you lift up your right leg?
No, I can't lift it.
Okay, so there's full motor blockade of the lower limbs, which is a good sign. Next, we're going to check if he has any sensation to temperature, because remember the spinothalamic tract carries pain and temperature. So I've got a bag which has ice in it. So, can you feel that's cold on your face?
Yeah, that's
yes. Cold. Now, can you lift your top up, please? So we want to check if he has any sensation to cold. Does it feel cold there?
No, it doesn't feel cold. Okay,
that's good. Tell me when it feels cold, like your face.
Yeah, there's cold.
Cold, and it feels the same as your face?
Yeah, it's cold.
Okay, but below here it's not cold.
No.
Now we'll go up the other side. Tell me when it feels cold, like your face.
Yeah, about there.
About there? It's cold like your face?
Yes.
Like, okay, that's good. So the block seems to be working, and it seems to be up to the nipple level, which is the T4 dermatome. Okay, we've come to the end of our video on spinal anaesthesia, where we've reviewed the essential neuroanatomy. We've talked about how best to gain consent, which is by explaining the benefits of the procedure and also explaining the risks and then the alternatives. We've shown how you can perform the procedure by following a few simple steps. We've also shown how you can effectively check whether your block has worked. We're hoping that after this video you've gained enough confidence to go out there and learn by doing, because under supervision you can become an expert in spinal anaesthesia. Thank you.